Welcome everyone to this webinar, Recommendations of the National Advisory Committee on Immunization, NACI, on the use of the Moderna COVID-19 vaccine. My name is Aleksandra Wierzbowski and I am a project manager at the National Collaborating Center for Infectious Diseases. I will be your moderator today. NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning and policy. Before we begin, I would like to acknowledge that NCCID is located on the original lands of Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and on the homeland of the Métis Nation. There are a few housekeeping items I would like to bring to your attention. We are running this webinar through Zoom. For those having challenges with Zoom, we are also live streaming this presentation on YouTube. You can find the link in the email you received from Eventbrite yesterday or today for new registrants. If you have technical problems with Zoom or with accessing the live stream, please email us at nccid@umanitoba.ca. We will do our best to assist you. Today's webinar is to inform healthcare and vaccine providers on the NACI recommendations on the use of the Moderna COVID-19 vaccine. Following the presentation, there will be a short Q&A session. Please use the Q&A tab in Zoom to pose questions to our speaker. Please note we cannot answer all the questions, but we will do our best. Lastly, the event is live and is being recorded. The recording and the presentation slides will be available on the NCCID website after the webinar. Without further ado, I would like to introduce our speaker, Dr. Shelley Deeks. Dr. Shelley Deeks is the Chief Health Protection Officer at the Public Health Ontario and the Executive Lead for the COVID-19 Public Health Response at the Public Health Ontario. She is an Associate Professor at the Dalla Lana School of Public Health at the University of Toronto and is the Vice Chair of Canada's National Advisory Committee on Immunization, NACI. With over 20 years of experience as a public health physician, Dr. Deeks has worked at all levels of the public health system in Canada and at the national level in Australia. She holds fellowships in public health in both Canada and Australia. I welcome Dr. Deeks to take the microphone.
Hey, good morning, everybody, and thank you, Alexandra. If you can put up the slide deck, please. Thank you very much. Okay, as Alexandra indicated, I'm going to be speaking to you today about the recommendations of NACI, Canada's National Advisory Committee on Immunization, on the use of Moderna COVID-19 vaccines. These recommendations were released on December 23rd. If you go to the next slide, I don't have any declarations of interest to declare other than I'm a very strong vaccine believer. Go to the next slide, please. Okay, so the objectives of today's presentation are to describe the characteristics of Moderna's COVID-19 vaccine platform, to summarize the clinical evidence for Moderna COVID-19 vaccine as we know so far, to summarize our NACI recommendations on the use of the vaccine, and to summarize key information on handling and administrating the vaccine. We can go to the next slide, please. Okay, so Moderna COVID-19 vaccine was authorized on December 23rd by Health Canada for use in the country for individuals 18 years of age and older. I will be talking about NACI's recommendations on the use of Moderna vaccine, but also Pfizer vaccine. They're both mRNA vaccines, and the recommendations apply to both vaccines and no other vaccines, because these are the only two vaccines currently available in Canada. Up-to-date recommendations on the use of the vaccines and full detail and supporting evidence can be found on the NACI statement. The link is there on the screen. We are revising the NACI statements as vaccines get authorized. So we initially did the Pfizer vaccine statement, and now the new release from December 23rd has information on both Moderna and Pfizer. We go to the next slide, please. Okay, so what is NACI? So NACI is an external advisory body to the Public Health Agency of Canada, and we develop evidence-based advice on vaccines approved for use in Canada. We have been around a very long time. We have celebrated our 50th anniversary a few years ago, and we're actually one of the oldest advisory committees in the world. NACI is comprised of experts in the field of pediatrics, infectious disease, immunology, pharmacy, nursing, epidemiology, pharmacoeconomics, social science, and of course, public health. Our advice is published in the form of NACI statements that are typically summarized in the Canadian Immunization Guide, but also posted individually on FACTS websites. So given the speed at which the COVID vaccine are being approved for use, the NACI recommendations on the use of COVID-19 vaccines are evergreen. They're not in the guide, but they are on the Public Health Agency of Canada's website. And the link for more information on NACI is at the end of the screen. If we can go to the next slide, please. Okay, so I'm first going to start with the characteristics of the vaccine, and then I will go into the recommendations. So the next slide is entitled, What is Moderna's COVID-19 vaccine? It, similar to Pfizer, is a messenger RNA vaccine. Lipid nanoparticles are used to deliver the messenger RNA directly into the cell. So it goes into the cells, not into the nucleus of the cell. mRNA coding for spike protein, that's the antigen, gets translated, and it is a new technology. This is the second vaccine that has used this technology. Of course, the first being the Pfizer product. Both vaccines elicit antibodies and T-cell response. One of the benefits for these vaccines is that it is a very fast manufacturing timeline. And as I said, Pfizer also uses an mRNA vaccine. So what the little schematic on your right shows is that the mRNA is embedded within the lipid nanoparticle. It enters into the cell, and then there is the cell reads the message basically and develops the protein, which is the antigen that then goes to the cell membrane and elicits the immune response. Next slide, please. So how does the vaccine work? So vaccine antigen, and I've already spoken a bit about this. Vaccine antigen is mRNA encoded for the SARS-CoV-2 spike protein. So the mRNA is very unstable. The mRNA lipid particle is made of two parts. In the center is the mRNA, and surrounding it is the lipid. The lipid allows the mRNA to enter into the cell and the spike gene to be translated into protein, which acts as the antigen. Lipids don't mix well with water, so the mRNA lipid nanoparticle vaccines have special storage and handling requirements, and that's why we say there should be no vigorous shaking of the product. If we go to the next slide, please. This slide shows a comparison of the Moderna and the Pfizer COVID-19 vaccines. So you can see the similarities as well as the differences. So both are messenger RNA vaccine and they use the same technology. They, while Pfizer was authorized in Canada basically the second week of December, Moderna was authorized December 23rd. The age that they're authorized for is slightly different. So Pfizer is authorized for people 16 years of age and older, whereas Moderna is authorized for individuals 18 years of age and older. The dosing is also different. This is a really important difference to be aware of, in that there's two differences here. One is that Pfizer requires addition of a diluent, whereas Moderna doesn't. The dose of Pfizer is 0.3 mils, which is a little bit unusual for our typical vaccines, whereas the Moderna vaccine is 0.5 mils, which is a more typical dose level that we deliver. The schedules are also slightly different. So both are a 2-dose series, with the Pfizer vaccine being 2 doses given 21 days apart was the recommended interval in the trials, versus Moderna 2 doses given 28 days apart. Now, what we've done in the NACI statement is identified minimum intervals. So the minimal interval for Pfizer is 19 days, whereas the minimal interval for Moderna is 21 days. And our recommended interval for both is 28 days, so 4 weeks apart. Both are delivered intramuscularly. Both have the same nature of the antigen, so they both have our perfusion spike protein. Neither of the vaccines have an adjuvant, and they are both delivered in multi-dose vials, although the size of the multi-dose vial differs. So the Pfizer product is 5 doses in the multi-dose vial, and the Moderna product is 10 doses. Both of them are preservative-free. Go to the next slide. And the next slide. Okay, so now I'm going to be talking about some of the clinical trial evidence. And before I do, it's important to recognize that these trials are ongoing. So both of these products have received interim authorization, but that does not mean that the trials have ceased. And importantly, we at NACI will continue to follow the evidence as it emerges, and we will update the statements as more evidence emerge. So we've had pivotal phase 1, 2, and 3 trials being conducted for Moderna. We have evidence on efficacy, immunogenicity, and safety is available for adults 18 years of age and older. And of course, this was required for Health Canada to authorize the vaccine. It's important to note that the studies didn't include participants from long-term care facilities. I will also tell you when we get to the slides, other participants who were excluded from the studies. The phase 3 portion of the trial involved 30,413 study participants randomized 1-to-1 to receive either 2 doses of the vaccine or a placebo. Trial data available to date are for an interim analysis. So as I said, the studies are ongoing. Therefore, the time of follow-up is not consistent, but was for a median of 2 months after the second dose. And the maximum follow-up for the data, for the trial data that we've reviewed at NACI was 14 weeks as of November 25th for all participants. So that's why we continue to say that we have short-term information only. It's important at this time to just note that although right now we only know the results of the trials at to maximum follow-up of a little over 3 months, those trials are ongoing, and we will, as time evolves, we will get further information about medium-term follow-up and long-term follow-up. And the trials are always going to be ahead of the population who are being immunized because they started months ago. So we will always be a few steps ahead in our recommendations prior to the population being at those time points. We go to the next slide. So here is some other important exclusions. I mentioned long-term care was where people in long-term care were excluded from the trials. Other exclusions were women who were pregnant or breastfeeding were excluded. Anyone with an immunodeficient or immunosuppressed condition were excluded. This did not include excluding people with stable HIV. So rather than stating that as a double negative, I'll say that people with stable HIV were included in the study. Anyone with a known history of SARS-CoV-2 infection were excluded. Anyone with a known or suspected allergy or history of anaphylaxis, urticaria, or other significant adverse reactions to the vaccine or its excipients were excluded. Those who have contraindications to intramuscular injections, or anyone with a receipt of blood or plasmid products or immunoglobulin 3 months before a vaccine administration were excluded. Importantly, people with chronic conditions were not excluded from the study. If we go to the next slide. So now I'm going to summarize some of the evidence. So in the clinical trials, the Moderna COVID-19 vaccine was efficacious against symptomatic confirmed COVID-19 over the short term. And I've already explained to you why we're emphasizing over the short term, and that's just simply because of the duration of follow-up to date in the studies. So what the studies show is that there was 185 confirmed COVID-19 cases in the placebo group at least 14 days after the second dose, compared to over 11 in the vaccine group. The vaccine efficacy estimates are in the next slide. For those who only received one dose, there were 39 confirmed COVID cases in the placebo group that occurred at least 14 days after dose 1, compared to 7 in the vaccine group. The Moderna COVID-19 vaccine was efficacious against severe COVID-19 in the short term. There were 30 confirmed severe COVID-19 cases in the placebo group at least 14 days after dose 2, compared to 0 cases in the vaccine group. We go to the next slide. So these are the vaccine efficacy estimates with the 95% confidence intervals. And you can, I'm sure you all agree with me, they're very high. So in terms of preventing confirmed cases of COVID starting 14 days after dose 2 among people without prior evidence of SARS-CoV-2 at baseline, the vaccine efficacy was 94%. Among participants who had received at least one dose, regardless of prior COVID-2 infection, the vaccine efficacy was 93%. And that was confirmed cases of COVID-19 starting 14 days after the after dose 2. I want to just pause here to just flag that says at least one dose. So it doesn't say only one dose. So most of these participants had gone on to receive 2 doses. In terms of confirmed cases of COVID-19 starting 14 days after dose 1, and among participants without prior evidence of COVID-2 infection at baseline, the vaccine efficacy was 95.2%. And in terms of preventing severe confirmed cases of COVID-19 starting 2 weeks after dose 2, among participants without prior evidence of SARS-CoV-2 infection, the vaccine efficacy was 100%. The confidence interval was non-evaluable because there was no severe cases in the vaccinated arm. We go to the next slide. So there's currently insufficient evidence on the duration of protection and on the efficacy of COVID-19 vaccine in preventing hospitalization and preventing death. Although I did share with you the vaccine efficacy in severe infection, which would include people that died. There's currently insufficient evidence on preventing asymptomatic infection, although there is 14 participants in the vaccine arm who were previously seronegative before dose 1, who had asymptomatic infection at the second time point versus, which was after dose 1, versus 38 participants in the placebo arm. The company hasn't done any formal efficacy data as yet. And of course, that analysis is ongoing. And there's currently insufficient evidence on whether the vaccine reduces transmission of SARS-CoV-2. So we fully expect that over time, we will have evidence about a number of these endpoints. However, it's just too early to say now. If we go to the next slide. In terms of safety, so safety evidence was based on the interim analysis as well of 30,350 participants with a median follow-up of 49 days after dose 2 and 78 days after dose 1. So I know a number of people were interested about the long-term follow-up for safety, and just stating here, similar to vaccine efficacy, the current duration of follow-up is relatively short. So less than 2 months after dose 2 for safety. No serious safety concerns have been identified to date in the clinical trials. However, studies are ongoing. There have been 7 serious adverse events in vaccine recipients that were considered to be related to the trial intervention, including 2 cases of autoimmune disease, which were reported among vaccine recipients who had hypothyroidism. And there were 5 serious adverse events that occurred in placebo recipients. In terms of the 7 SAEs or serious adverse events in vaccine recipients, there was 1 case of intractable nausea and vomiting, 2 cases of facial swelling, 1 case of B-cell lymphocytic lymphoma, 1 dyspnea with exertion and peripheral edema. And then the 2 cases of autoimmune disease that I mentioned was 1 case of rheumatoid arthritis and 1 case of autonomic dysfunction. We go to the next slide. Similar to Pfizer, some adverse events were very common, particularly after the second dose. So events tended to be more common after the second than the first dose. And they were reported to affect more than 10% of people who received the vaccine. However, most of these were mild or moderate and transient in nature. So I indicated that they were more common in people receiving the second dose than the first. They were also more common in younger recipients compared to those over 65 years of age. Some of the common adverse events included pain at the injection site, fatigue, headache, muscle pains, joint pains, axillary swelling and tenderness, chills, nausea, and vomiting. Participants who inadvertently received the vaccine while pregnant are currently being followed. So I mentioned that pregnant women were excluded from the study, but there were 13 women who became pregnant during the study, and they are still being followed as we speak. And at the time that we saw the analysis, there were no pregnancy outcomes among the vaccinated individuals as yet. We go to the next slide. So now into the NACI recommendations. Next slide, please. Okay, the following recommendations apply to both available COVID-19 vaccines unless specified. And as I've said, I think 3 times, both are mRNA vaccines. The next slide, please. Okay, so in terms of vaccine administration, both vaccines are administered intramuscularly in a 2-dose schedule. And I have previously explained the differences. So here you can see once again that the dose volume for Moderna is 0.5 mils versus 0.3 mils for Pfizer. And the minimal interval for Moderna is 21 days, with the authorized interval being 28 days. And for Pfizer, the minimal interval is 19 days. However, providers can use either 21 or 28 days. The same vaccine product should be used to complete the vaccine series. So if an individual is immunized with Moderna, they should complete the series with Moderna, and vice versa for the Pfizer product. If administration of the second dose of vaccine is delayed, the second dose should be administered as soon as possible. There currently are no data on maximal intervals between doses, or, as I said previously, any data on medium or long-term efficacy of either vaccine. We know that the peak humoral response occurs about a week after the second dose, and we postulate that long-lasting immunity may not be activated without a second dose. So we're seeing a prime boosting phenomena. We go to the next slide. Importantly, serologic testing does not need to be conducted before or after receipt of a COVID-19 vaccine to assess susceptibility to either the disease or immune response in the recipients. COVID-19 vaccines should not be given simultaneously with other vaccines, either live or inactivated at this time, unless such vaccines are required for post-exposure prophylaxis. COVID vaccines should also not be given simultaneously with monoclonal antibodies or convalescent plasma. We go to the next slide. In terms of contraindications, the COVID-19 vaccines are contraindicated in individuals with a history of anaphylaxis after previous administration of the vaccine. Individuals with a history of severe allergic reaction to a component of COVID-19 vaccine should not receive the vaccine. So polyethylene glycol is a potential allergen in both products. So it's in Moderna as well as Pfizer, and has been known to cause type 1 hypersensitivity reactions. In situations of suspected hypersensitivity or non-anaphylactic allergies to COVID-19 vaccine components, investigation is indicated, which may lead to immunization in a controlled setting. Consultation with an allergist is advised. If there is a special concern about a possible allergy to a component of COVID-19 vaccine being administered, as an extended period of observation post-vaccination to 30 minutes may be warranted. We go to the next slide. In terms of precautions, in individuals with bleeding disorder, the condition should be optimally managed prior to immunizing to minimize the risk of bleeding. Individuals receiving long-term anticoagulation are not considered to be at higher risk of bleeding complications following immunization and may be safely immunized without discontinuation of their anticoagulation therapy. As a precautionary measure, and in light of the need to be able to monitor for COVID-19 vaccine adverse events without potential confounding from symptoms of COVID-19 or other coexisting illnesses, it would be prudent to wait until all symptoms of an acute illness are completely resolved before vaccinating with an authorized COVID-19 vaccine. Next slide. Vaccination of individuals who may be currently infected with SARS-CoV-2 is not known to have a detrimental effect on the illness. However, vaccination should be deferred in symptomatic individuals with confirmed or suspected SARS-CoV-2 infection or those with respiratory symptoms in order to avoid attributing any complications resulting from infection with SARS-CoV-2 to vaccine-related adverse events following immunization and to minimize the risk of COVID-19 transmission at the immunization clinic or venue. If any persons are identified with symptoms at arrival at the immunization clinic or venue, they should be instructed to follow current local public health measures. Next slide, please. In terms of post-vaccination counseling, NACI recommends that prophylactic oral analgesics or antipyretics, for example, acetaminophen or ibuprofen, should not be routinely used before or at the time of vaccination, but their use is not contraindicated to vaccination. There currently is no evidence on the benefit from administration of oral analgesics for the prevention of immunization injection pain or systemic reactions. Oral analgesics or antipyretics may be considered for the management of adverse events if a vaccine recipient gets pain or fever if they occur after vaccination. Next slide, please. Okay, so now to the NACI recommendations. So NACI recommends that a complete vaccine series, so that is a 2-dose series of COVID-19 vaccine, should be offered to individuals in the authorized age group without contraindications to the vaccine. In the context of limited vaccine supply, initial doses of COVID-19 vaccine should be prioritized for the key populations outlined in our guidance on the prioritization of initial doses. The rationale for this recommendation is that available COVID-19 vaccines are highly efficacious in the short term against disease, and there are no significant safety concerns. COVID vaccines are authorized in individuals 18 years of age and older for Moderna, 16 years of age and older for Pfizer, based on the pivotal clinical trials conducted in these age groups. Medium and long-term follow-up are underway and needed and will be done, and NACI will continue following the evidence and update the recommendations as we get more information. If we go to the next slide, please. In terms of public health measures, NACI recommends that all individuals should continue to practice recommended public health measures for prevention and control of SARS-CoV-2 infection and transmission, regardless of vaccination with COVID-19 at this time. As I've mentioned, there's insufficient evidence on the duration of protection of the vaccine and the effectiveness of the vaccines in preventing asymptomatic infection and reducing transmission of SARS-CoV-2, which is why we've made this recommendation. Although there is preliminary descriptive evidence suggesting Moderna may reduce asymptomatic infection, but the evidence is insufficient at this time to recommend discontinuing of public health measures. And there's no evidence on the use of COVID-19 for post-exposure prophylaxis. Next slide, please. Among persons with previous infections, NACI recommends that a complete series with COVID-19 vaccine may be offered to individuals in the authorized age group without contraindication who have had previous COVID-19. In the context of limited vaccine supply, initial doses may be prioritized for those who have not had a previously PCR confirmed infection. The rationale is there's a lack of evidence in this group, but the level of protection from previous infection is unknown. As I've said, we don't recommend testing for infection prior to receipt of vaccine. Vaccination may be delayed for 3 months following a PCR confirmed infection, as reinfections reported to date have been rare within the first 3 months following the first infections. And of course, as I've said, all symptoms of an acute illness should be completely resolved before vaccinating. Next slide, please. In terms of the immunosuppressed populations, NACI recommends that COVID-19 vaccines should not be routinely offered. And that's a little bit different than our previous recommendation. So what we're saying is it should not be routinely offered to individuals who are immunosuppressed due to disease or treatment until further evidence is available. However, a complete series with the COVID-19 vaccine may be offered to individuals in the authorized age group in this population if a risk assessment deems that the benefit outweigh the potential risk for the individual, and if informed consent includes a discussion about the absence of evidence of use of COVID-19 vaccine in this population. The rationale for this recommendation is that immunosuppressed individuals were excluded from trials, so we have absolutely no evidence of efficacy and safety in this group. However, no safety signals of concern have been noted to date in non-immunosuppressed participants with an immunocompromising condition included in the clinical trials, which is why we have emphasized that clinicians need to do a risk assessment prior to determining whether to vaccinate their patients. People living with HIV were included in the trials and those that are immunocompetent may be vaccinated. If we go to the next slide, it's about autoimmune disease. NACI recommends that COVID-19 vaccines should not be offered routinely to individuals with autoimmune conditions until further evidence is available. However, a complete series of COVID-19 vaccines may be offered to individuals in the authorized age groups in these populations if a risk assessment deems that the benefits of the potential risk for the individual outweigh the potential risks, and if an informed consent discussion about the insufficiency of evidence on the use of COVID vaccine has occurred. So as I had indicated, there's very limited data on COVID-19 vaccination in individuals who have an autoimmune condition. The spectrum of autoimmune conditions is diverse, and the balance of benefits and risks must be made on a case-by-case basis. Previous mRNA vaccine technologies may have elicited inflammation and theoretically exacerbated existing autoimmune diseases, which is why we have framed the recommendation such in a precautionary way. Current applications of mRNA technology for COVID vaccines have been optimized to reduce this risk. However, further evaluation is needed. And again, we are following the study and data, and we will revise this recommendation as further information is available. We go to the next slide. It's about pregnancy and breastfeeding. And similar to the others, we've worded this that COVID vaccine should not routinely be offered to individuals who are pregnant until after completion of pregnancy, until further information is available. However, a complete series with a COVID-19 vaccine may be offered to pregnant individuals in the authorized age group if a risk assessment deems that the benefit outweighs the potential risk for the individual and the fetus, and if informed consent includes a discussion about the absence of evidence on the use of COVID-19 vaccine in this population. If we go to the next on breastfeeding, the wording is, for breastfeeding, the wording is similar to pregnancy. The rationale for this is that anyone who was known to be pregnant or breastfeeding at the time of vaccination were excluded from the trials. There is a lack of evidence on efficacy and safety in this group, as only a few individuals actually became pregnant during the trial. This occurred both with Pfizer and Moderna, and those women are currently being followed. There's currently no evidence to guide the time interval between the completion of COVID-19 vaccine series and conception. In the face of scientific uncertainty, what we've said is it would be prudent to delay pregnancy by 28 days or more after the administration of the complete 2-dose vaccine series of an mRNA vaccine. And we've also noted that an mRNA vaccine may be administered anytime after pregnancy, taking into consideration whether an individual is breastfeeding. Individuals who become pregnant during vaccine series or shortly thereafter should not be should not be counseled to terminate the pregnancy based on having received the mRNA vaccine. We go to the next slide. For children and adolescents, we recommend that COVID-19 vaccines should not be offered to individuals who are not in the authorized age group, recognizing that Pfizer's indication is slightly lower, so 16 versus Moderna's at 18. However, a complete series with Pfizer may be offered to individuals 12 to 15 years of age who are at very high risk of severe outcomes of COVID-19, for example, due to a pre-existing medical condition known to be associated with increased risk of hospitalization or mortality, and who are at increased risk of exposure due to living, for example, in a congregate care facility. If a risk assessment deems that the benefit outweighs the potential risk for the individual, and if informed consent with the individual and the parent or guardian includes discussion about the insufficiency of evidence on the use of vaccine in this population. There is very limited data on safety and efficacy of the Pfizer vaccine in individuals 12 to 15 years of age, and there is no evidence in Moderna. And again, further evidence will be available as these trials progress. We go to the next slide. Okay, the next part of the presentation is on handling and administering the Moderna COVID-19 vaccine, and I am delivering this on behalf of the logistics team at the Public Health Agency of Canada. If we go to the next slide. So, storage and handling. The storage is for Moderna is different than Pfizer. So storage is at -25 to -15 degrees Celsius until expiry. It can be stored at 2 to 8 degrees for up to 30 days, but should not be refrozen and should not be stored on dry ice. When transporting to another site, frozen transport is recommended. However, limited transport in the liquid state at refrigerated temperatures, so that is between 2 and 8 degrees Celsius, is possible with special attention to temperature control and limiting jostling of the products. Again, do not store on dry ice, and it's essential that temperatures are monitored. So this vaccine has more easier, can I say, storage conditions than the Pfizer product. We go to the next slide. In terms of thawing, when you thaw from freezer to room temperature, it requires about 1 hour to thaw and can remain at room temperature for 12 hours, but importantly, only 6 hours after the vial has been punctured. If you're thawing in the refrigerator, it requires 2.5 hours to thaw. It can stay in the refrigerator for up to 30 days, and it needs to be kept at room temperature for at least 15 minutes before administering the vaccine. And of course, it cannot be refrozen. All product must be used within 6 hours of first puncturing the vial. And remember, there's 10 doses in the vial. Indicate that the appropriate dates and time on the vial so that the expiry point is clear. So it's very important to ensure proper marking on the vial to indicate the start time and the end date. but need to be clear which time is which, particularly the puncture time. We go to the next slide. In terms of drying up, the product should be checked for foreign particulates or discoloration. It should be a white to off-white suspension. It may contain white or translucent product-related particulates. Use a alcohol-based hand rub, gently swirl the vial, do not vigorously shape it. Swab the vial stopper with the alcohol wipe, let it dry. Ensure the needle is tightly attached to the syringe by giving it an extra turn. Using aseptic techniques and a new needle and syringe, draw the dose, which is 0.5 mils. Mark the date and time of first puncture on the vial. And as I've said, I think multiple times, it must be used within 6 hours of first puncture. And then this process is repeated until the vial is used. And as I've said, 10 doses are available in each vial. The manufacturer has indicated that the product is stable in the syringe for up to 6 hours, so it must be used within 6 hours of the first time the vial is punctured. If preloading, only draw up enough to keep the clinic running smoothly and use as soon as possible. Next slide. In terms of administering the vaccine, once again, use an alcohol-based hand rub. Check the syringe to ensure no particulates or discoloration and that it's the correct dose of 0.5 mils. Prepare the skin, give the 0.5 mils dose IM in the deltoid, discard the needle and syringe immediately into the sharps container and use an alcohol-based hand rub. And then, of course, the client should return 1 month later for the second dose. And importantly, we don't recommend to restart the series if there is a delay in return. Next slide. This is the landmarking slide. We can go to the next slide. And this is a comparison of the two products. And we've seen this in the past, so I don't want to spend much time on this, but just flagging the storage conditions, which are different in terms of Moderna requiring regular freezer conditions and Pfizer requiring the -80 to -60 storage. Next slide, please. And that's it. This slide just shows the NACI members and our liaison representatives and the ex officio representatives. We go to the next slide. This slide indicates the high consequence infectious disease working group, which is basically the COVID vaccine working group members. And I think that is it. We can go to the next slide where there is additional resources. And now we have a few minutes for questions.
Thank you, Dr. Deeks. So now we're going to begin the Q&A session of this webinar. So once again, for all of you who would like to pose a question for Dr. Deeks, please use the Q&A tab in your Zoom window. And please note that we will try to get to as many questions as possible, but we cannot address them all today. So I would like to start off with a question that has been mentioned by a lot of the attendees. And Dr. Deeks has already addressed this in great length, but could you please talk more about what is recommended and what is known about the use of the Moderna vaccine in the immunocompromised population, those with autoimmune disorders and those on immunosuppressive therapy? Could you define what conditions and who falls into the immunocompromised groups for which the vaccine is contraindicated?
Yes, as I mentioned, there is very limited information on immunosuppressed conditions because those participants were not included in the trials. NACI in the Canadian immunization guides defines immunocompromising conditions, and we're recommending that people use those definitions. So it's conditions that cause immunosuppression, but it also includes medications that cause immunosuppression. Although there is limited data now, we fully expect that data will emerge as populations are vaccinating. And we will, as soon as we have enough information to modify this recommendation, we will be making changes to the recommendations for both the pregnancy, autoimmune disease, and immunosuppressive conditions. I know people are very anxious to know more, but unfortunately there is very limited data available, which is why we say you really need to do a risk assessment looking at the individual's condition, but also the epidemiology of the outbreak at the time of vaccinating, and how that individual is interacting in their community. So a risk assessment needs to be done to take all into account.
Okay, thank you. You spoke in great length as well about the differences between Moderna and the Pfizer vaccine. Could you elaborate on the difference in the dose between the two vaccines that are currently available, and why is there a difference in dose? Why is one larger? What are your thoughts about that, and what has been known about this?
Well, one is, I can't specifically say, it's not unusual to have products have different dosing. So that is just the way the product was manufactured. So I don't think that there is any reason for concern that they are different doses. One is 0.3, one is 0.5. The reason that I recommended or that I stressed it so much during my talk really is that people need to be aware of the different doses and not immunize with 0.5 of the Pfizer product or 0.3 of the Moderna product, because then you won't be getting an appropriate dose.
Okay, thank you. Can you speak to the efficacy of the vaccine, of the Moderna vaccine, with just one dose?
Yeah, so I gave you the information about one dose efficacy. But the way that the trial, was conducted was that the vast majority of people went on to receive a second dose. So the efficacy for one or more doses was over 90%, but we don't know the vaccine efficacy nor the duration of protection for people that only received a single dose. And that is important because, as I mentioned when I talked about the immune response, what we saw with the immunogenicity data is that there was an immune response after one dose, a very strong immune response after one dose. After 2 doses, there was a boosted response with the peak in levels at about 2 weeks after the second dose, and then a gradual decline to 90 days after the second dose, which was as long as has been followed. So why we're saying a 2-dose series is considered a complete series is because the majority of participants have received 2 doses, have been followed, and are continue to be followed for that duration of time. We just don't have enough information as yet to know whether one dose will be enough in the long term to maintain protection. And of course, we're in this for a long haul. We're coming into the end of the first year of COVID-19, and we need to ensure that people have a robust and long-lasting immune response.
Okay, thank you. To follow up on this, a question came in. Is one dose of Moderna vaccine being considered? And when might that be decided? Could you comment on this?
No, I think I've just commented on the one dose issue.
Okay, thank you. Could you describe the difference between the COVID-19 messenger RNA technology compared to the traditional vaccines?
Yeah, so in terms of the traditional vaccine, the antigen tends to be injected into as part of the immunizing the individual. So whether it's a protein, whether it's the whole virus, like an attenuated or weakened strain of the virus, for example, for measles, mumps, and rubella, or it's a virus-like particle for HPV, the antigen is injected and the host, or in this case human, makes an immune response to that antigen. For the mRNA technology, the mRNA is kind of the messenger, and it goes into the host cell, and it's actually the host, or us, that makes the antigen that then causes our cells to mount an immune response.
Okay, thank you. Can you talk more about what is recommended and what is known about the use of Moderna vaccine in patients with allergies, specifically food allergies, latex allergies, or other drug allergies?
Sure. So in terms of allergies, as I indicated, people with allergies to components of the vaccine were excluded from the clinical trial. Not a lot is known in terms of allergies, other allergies, and they are not contraindicated to receive the vaccine. However, what we have said is that if clinicians or immunizers are concerned that they have an individual who is atopic, that they should extend the period of observation to 30 minutes.
Okay, thank you very much. Can you talk about recommendations regarding vaccination in the long-term care facilities? Should all residents, regardless of whether they had COVID-19 infection, receive or not, receive the COVID-19 vaccine?
Yeah, so that's an excellent question. In terms of vulnerable populations, and I think we all agree that people in long-term care are a very vulnerable population. As long as they don't have a contraindication, they should receive the vaccine. And I did mention in the talk that people that have had a previous history of COVID-19 can receive the vaccine. What we're saying, though, is that typically you could wait about 3 months. However, we recognize that logistically that may not be possible, and it would be fine to vaccinate people that have had a past history of COVID-19.
Okay, thank you. Can you talk about the evidence for the Moderna vaccine to stop transmission of COVID-19 from one person to another, to reduce hospitalizations, to decrease maybe the severity of the disease?
Yeah, well, I have done that, but in terms of there is no evidence at this time that the vaccine will reduce transmission. We just don't know as yet. I'm very confident that we will know. However, we just don't have that information now. I think it's important for people to recognize that it is not unusual as a vaccine is first licensed to not know, for there to be gaps in knowledge. We typically don't know what the duration of protection for a vaccine is. And for neither Moderna nor Pfizer do we know the duration of protection. Typically, though, we would know longer than like 2 or 3 months. But because of the way these vaccines have been authorized, we at this point only know about short-term protection. In terms of severity, I did present the data on vaccine efficacy against severity. And it was, the VE was 100%, and there was no cases of severe outcome in the vaccine recipients. The data are not in yet for hospitalization, but I suspect that, as the trial length continues, we will have evidence about other outcomes that are just not available as yet.
Okay, thank you. Can you talk more about what is known about the safety of the Moderna vaccine? Can you talk more about the side effects? And can you maybe also talk about how can healthcare providers reassure their patients regarding their concerns about long-term consequences of COVID-19 vaccines?
Sure. This will have to be the last question because I know that we're over time. And I actually have another meeting I need to get to. In terms of safety, that is well detailed in the NACI statement. So I would recommend that your listeners actually go to the NACI statement to get the full amount of information that is available. Briefly though, as I indicated in the presentation, there were a number of local and systemic adverse events that were relatively common at about 10%, which included local pain in the injection site, redness in the injection site, some swelling and tenderness in of the lymph nodes around the injection, fever, muscle aches, pain. Those were all relatively common in vaccine recipients. There was 7 serious adverse events, which I think I went over quite in detail in the talk. And those were considered to be related to the intervention by the investigators. That is not unusual for a clinical trial. And so importantly, the manufacturer is continually following the trial participants for, I believe, up to 2 years. As I said in the presentation, the recipients at the time of license had only been followed for 2 months. So those people will continue to be followed. In addition, as the vaccine is rolled out globally, we're part of a global network for pharmacovigilance. And we will be monitoring at the provincial, territorial, national level adverse events that are being reported in other countries, as well as adverse events that are being reported in Canada. The same is going to be true with respect to vaccine effectiveness. As we'll get further information from the clinical trials as they progress, but we're also going to benefit from vaccine effectiveness studies from countries, including Canada, as the vaccine is rolled out. So we will know more about how effective this vaccine is in multiple populations, including immunosuppressed and pregnant women, and how safe it is.
Okay, thank you so much. So unfortunately, we appreciate everyone's questions coming in, but we will not be able to get to any more questions as Dr. Deeks has to go and we are past time. So I thank Dr. Deeks for presenting today, and I thank all of you for joining. I would like to point out that NCCID will be hosting more COVID-19 vaccine webinars. Please check our website, nccid.ca, for more information. We will also be promoting on social media. Today at 3 p.m. Eastern Time, we will be hosting this same webinar in French, and registration is still open for those of you who might be interested. So before I conclude, I would like to ask that you fill out our short evaluation when you leave the webinar. These surveys are important to our future planning. Thank you and stay safe.